Steve, if you're seeing an early stage 1 or 2 patients, give us some practice pearls. Like, what are you thinking about?
Yeah, and I love the way you phrase that question because I think it really is the staging or like the severity really does make you look at patients differently.
Mhm.
So those early stage diseases, sometimes it's so early you're not even 100% sure if you can call it HS yet, right? Like they've
Right.
had a couple nodules come up and you're going, well, maybe just bad luck you've had two of them, but let's keep an eye on it. Usually those patients, I'll tell them, you may have this thing called HS, and then I spell it out for them because no one knows how to spell hidradenitis suppurativa. But I tell them, don't freak out. If you go home and you look this up online, don't freak out when you see how bad it can get. We're not going to let you get there. You're with us. We're going to get it under control. But the good thing is a lot of those early treatments kind of overlap. Like you said, the antimicrobial washes. So we've got like benzoyl peroxide, chlorhexidine. We've got even the hypochlorite bleach and zinc, like the zinc parathione washes have shown benefit. None have been studied with trials or rigorous studies, but they're kind of like expert opinion. We've all seen that they can be helpful, especially in early disease. Even in later disease, I still give them to patients. I say, I don't know how much it's helping, but like you said, we need all the help we can get. It's all hands on deck. So if it helps even a little bit, it's worth it. Then we usually do like a topical clindamycin antibiotic. Some people will reach for resorcinol, which is commercially available outside of the US, like in Europe, but here you have to get it compounded. I've just had trouble with my patients being able to afford compounded meds, so I don't use it a lot, but some people do reach for it if that's something you want to look into and get into. And then a lot of times it's a little course of one of our antibiotics, like doxycycline, minocycline, clindamycin. A few years ago, the original studies, we used a lot of Clinda plus rifampin,
Yeah.
both 300 milligrams twice a day. And then some very smart people realized rifampin is a strong CYP3A4 inducer. So when you take both of them, after a while, your clindamycin levels are zero. So now they did a study that showed Clinda alone was just as good and no increased risk of side effects as the duo. So now I've switched. I just do the clindamycin 300 milligrams twice a day by itself. And I'm seeing similar results to when I was using it with the rifampin. And now I don't have to warn people about orange tears and secretions.
Yeah.
But the other important thing with those early patients is when do you really pull the trigger and talk about a biologic? Because we have a big problem of waiting too long. And part of it is the patients often don't get to us when they're early. It's getting better, I think, with social media and with increased disease awareness and just more info out there. Patients are kind of self-diagnosing sooner, and even doctors, the frontline doctors in primary care are getting to like know HS a little more, recognize it. So one of my favorite is definitely if a patient has any kind of evidence of tissue damage. I think about it like acne. You know, I see scarring, we're talking isotretinoin right away. I've got to stop any more scarring from going on. So if I see tissue damage, which is like significant scarring or even a tunnel forming, then I know, all right, we got to turn this off right away. But even before the tunnel is that tricky one of when do I start a patient? And so I like to use, in Europe, they have a scale they call the IHS4. And you basically count up the abscesses, nodules, tunnels. They each have a point value. And with that, if you have 3 inflammatory lesions, either abscesses or nodules, at the same time, that counts as moderate disease. And so sometimes I'll even ask patients that when they're still on that early side, like, have you ever had 3 active spots at the same time? Because that's just a predictor that they're probably going to go on, and it's probably time to start talking about something to really get it under control if we haven't been able to. Other things I love are in early disease, like you said, spironolactone for female patients.
Mm-hmm.
I love it. I've started to use a little more finasteride because you can use it in men or women. And in the studies, or it was just case series, not studies yet, so not a ton of evidence, but they sometimes started at a lower dose, but everyone ended up on the 5 milligrams daily. So I just jumped to the 5 right out of the gate. And then you're going to make sure you see the patients back because that early disease, you want to make sure you are sort of keeping it on your radar. And if it starts to get worse or if they're not responding to therapies, you're going to that next step and adding to their regimen.